Welcome everyone. This is Dr. Sharad Jaitly, your cardiologist from New York, on your favorite website, MuniMeterHealth.com, which is dedicated to educate you about the human heart and its illnesses, as also help enhance the clinical outcomes by combining medical education with the patient education at large from one end of the globe to the other. Thank you again for watching, learning, and sharing on MuniMeter Health. I also want to thank you and acknowledge that you are doing wonderful in terms of associating more and more so with my website and helping me support this cause freely to all. Thank you again. Without any further ado, I'd like to delve into the subject matter, and the matter of the subject being today, peripheral arterial disease. What is peripheral arterial disease? We call it PAD. Now, PAD is related to the arterial supply disorders that occurs in peripheral arteries, as simple as that. But peripheral vascular disease implies that wherever there is other vascular territories or categories of various arterial beds, including renal, for instance, or carotid. These are all peripheral vascular beds, if you will. Splanchnic systems, the GI, etc., involved, and then the lymphatics, and that also include the veins, the venous, which are the capacitance vessels. So if one defines peripheral vascular disease, you could include PAD there and include the rest of the arteries as well. But peripheral arterial disease usually is signifying the upper and the lower extremity arterial supply disorders, if you will, like the brachial artery in the arms, the subclavian arteries in the arms, or you'll have the femoral and the popliteal arteries, and the tibial and peroneal and dorsalis pedi arteries in the legs, if you will, or in the lower extremities. So that's the definition of the peripheral arterial disease. Now, what are the risks for having peripheral arterial disease? Let's understand the various risks, because obviously there are certain sects of population which are very, very prone for peripheral arterial disease. Number one is smokers. Across the globe, you'll see a lot of smokers who have peripheral arterial disease, and we'll get to the symptoms and signs in just a second. But smokers is a big category. Hypertensive individuals. All diabetics should be evaluated for peripheral arterial disease unless proven otherwise, because they do have atherosclerosis to begin with. Now remember, the baseline pathophysiology we'll just discuss in that a second, but diabetes and hypertension, they all have atherosclerosis, which is of an accelerated nature. Then you have high fibrinogen levels. These are specific cases where you have high fibrinogen levels. You may have high CRP, or we call it C-reactive protein, which is an inflammatory marker, and you may also have high homocysteine levels. And homocystinemia, we call it, or high homocysteine levels. And this could be, these are all markers of peripheral arterial disease, if you will. And then do not forget, of course, high cholesterol, because that is a biggie. That is prevalent in, much of the population across the globe. So having understood what the peripheral arterial disease risk factors are, let's understand what are the symptoms and signs. Well, the symptoms are very clear. The person will complain of pain mostly on walking. So and the distance gradually diminishes in order to produce the pain. And the pain is pretty reproducible. Like the person would say, look, I used to walk the 18 holes while I was walking the golf courses last year. Now I barely walk 9 holes, and I start to get pains in my calves, or pains in my tibial regions, or maybe in my thigh regions, etc. And that'll denote exactly where the obstruction patterns are. So this distance will eventually diminish, but normally it is very reproducible. It is also based on not only the distance, but also on the incline and the time spent during the time when. So all of this history is very, very important when somebody is asking questions about peripheral arterial disease to the patient. Now, so that's the common. The signs you will see, and it's called intermittent claudication, by the way. So just so that you know, it's called intermittent claudication. And claudication is derived from a Latin word. Claudere means pain or discomfort on walking. And so that's what it means, that the pain resolves at rest. As soon as the patient begins, as soon as the patient stops, the pain disappears and begins to walk, and the pain reappears. Okay. So now the symptoms, the signs are very typical, where there'll be absence of pulse or diminished pulses. So the pulse distally or at the site will be lessened. So that'll be one of the issues that one comes across here. And the other part is that one may also see there'll be discolorations. For instance, the extremities may feel cold and clammy, or with respect to one from the other, there might be blueness, or but those are very, very advanced peripheral arterial disease, and eventually, of course, the necrosis and the gangrene appears on those extremities. So remember that the higher the obstruction, the lesser will be the walking distance, and obviously the patient will then start to have rest pain, not just the intermittent claudication, but that'll progress to rest pain, as we call it. And rest pain is very, very critical, and sometimes it's very, very difficult to treat also, and patient may have to undergo emergent therapy at that point. Now, what are let's understand the pathophysiology. The pathophysiology is the following. You have the arterial supply, for instance, here, and then you have these capillaries, which are multiple, if you will, and then you have the venous. The venous will be, let me show you in this blue color here, and this is your venous vessel. So arterial, capillaries, and the veins. So all this capillary circulation that occurs, typically that's where the exchange of oxygen to the supplying muscles, and removal of all the toxins that have accumulated while the muscles are exercising, where the person is exercising. So this is where the action is. So not only you'll have an endothelial, the pathophysiology in these patients who have peripheral arterial diseases, that the endothelial thickening will occur. So there will be swelling of the endothelial cells, if you will. There will be RBCs that can get plugged here, for instance. The platelets will get plugged, and as a result, there will be lesser or more sludging, if you will. There will be hyperviscosity of the blood. There will be hyperviscosity in these settings. And of course, atherosclerotic plaques will be present throughout these arteries. So that will also contribute to the diminished blood supply, if you will. So the blood supply obviously is much diminished. So the arterial supply will be only diminishing as it progresses towards the capillaries. So in a nutshell, as the veins, they start collecting the blood, that will be will not be able to remove all the toxins. So the samples here will contain more of toxins, if you will, and the toxins will still be present within the capillaries, and they will not have been washed. So these are some of the symptoms and signs, but the pathophysiology is based mainly within the capillaries, which is where the action is, and that's what is the cause. Now, I want to move up further here, if I can go to the next page. Now let's draw a limb, for instance, the lower extremities, for instance. Now here is your limb, and if you will, and then this, okay, having understood this, say this is your limb. The circulation actually tends to progress slowly and more diminished way, if you will, as it progresses peripherally. So you may have an arterial systolic blood pressure in the femoral artery of, say, 140 systolic. We are just talking about systolic. And by the time you're reaching the mid-thigh region, it may be 138. By the time you're reaching the popliteal, it may be 128. And by the time you're reaching the ankle, which is the dorsalis pedi, or maybe the tibials and the peroneal arteries, it could be 110. So you're looking at a difference and a drop in the pressure heads as the arterial supply distals out, if you will. So there is a bedside study that's very freely available, and that's called ankle brachial index. So what one does is actually checks a pressure here by applying a cuff. If you apply a cuff here right in the thigh region, for instance, and check the pressure, and that'll be the pressure of your femoral artery, for instance. And if you apply the pressure here at the ankle, for instance, you will get the pressure of the ankle, obviously, and that'll be the pressure of your tibial arteries, if you will. So tibial artery or the peroneal arteries pressures can be obtained. So normally it's a good idea to get an ankle pressure, which is say in this case is 110, and then get a pressure in your arm. The arm, let's draw the arm here, for instance, and the pressures here in the arm could be seen the following way. If you were to tie a cuff here, and the pressures here in the brachial artery, for instance, brachial artery was 140. So if you were to look at the ankle brachial index, that means it's a ratio or the index between a systolic blood pressure of the ankle, which is 110 here, divided by the brachial pressure, which is 140. Now, 110 over 140 obviously is less than 1, and that is considered as abnormal. So remember that ankle brachial index, if it is 1 or greater than 1, if you will, that's normal. Less than 1 is abnormal. Then you have a range of 0.05 to 0.08. That signifies that these patients with ABI, which has 0.5 to 0.8, they must exhibit intermittent claudication. And when it is less than 0.5, that is considered critical. So those ABIs which are less than 0.5, they are considered as critical. And obviously these patients are either markedly symptomatic and they're just waiting to get operated. So peripheral arterial disease can be simply diagnosed by a bedside technique where one can actually tie a cuff, and just by regular sphygmomanometer and a stethoscope, or sometimes you can use a little peripheral Doppler if you like, and apply it here, and then you'll be able to get the brachial pressure. Then here similarly, tie a cuff at the ankle and check the dorsalis pedi pulses by a Doppler, and you can get the ankle pressure. So the ankle brachial index is basically an ankle pressure divided by the brachial pressure, which is in this case of course less than 1, and that is considered as abnormal. Okay, so very, very simple technique where ABIs can lead you to diagnose peripheral arterial disease. Now further testings are required, so let's move on to the further testings here. And what are the other diagnostic tests that one can really do? Well, one of the things that immediately comes to your mind, because you want to be non-invasive first without using any contrast, so use the duplex first. So try to understand and reduplicate literally what the ABI test that you performed earlier. A duplex ultrasound is based on actual measurement anatomically of the arteries, as well as the functional pulse velocity, if you will, through those arterial segments, like I showed you in that limb. And duplex ultrasounds will not only tell you the anatomical obstructions or indirectly, as well as it will also tell you about the functional, as I said, arterial stenosis, where exactly the stenosis are. Now, the other tests that you can employ are CTA, but they all require to ask the individual the history of allergies. Remember, because you're going to be using some contrasts here, and patients who are allergic to patients who have allergies, it's a no. So just very carefully, because you certainly don't want to stress out the kidneys here and renals because of the contrast not being eliminated in a setting, or sometimes even with the allergies. So there are two clear contraindications. One is history of allergies, and second is history of renal disease. You may not want to use these contrasts using or incorporating testings. So CTA, computed tomography angiography, then MRA, and they really are integrated to really pinpoint exactly where the obstructions are, whether it's in the fem-pop region, or whether it's in the pop-tibial region, or whether it's between tibial and dorsalis pedi, peroneal arteries, etc., etc. Wherever, so they will be able to tell you exactly where the locations, and not only the extent and how long are the obstructive patterns seen in those segments of arteries. Another one, of course, is contrast angiography, which is the gold standard, but that's an invasive study, remember that? So that is only done in the OR or in the cath labs, where the patient is just about to go for for surgical intervention. The risk factors, like I said, there are hypertension, diabetes. So lifestyle modification is really the goal now. Now let's understand what the management is. The management is clearly towards lifestyle modifications. If you can modify, obviously, no smoking sign is on. I always say that. So remember that patients will have to be off the tobacco. Hypertension needs to be better controlled. Diabetes needs to be better controlled. So all these things have to be very, very carefully analyzed. High cholesterol needs to be better controlled. Patient will require to be on a diet, obviously lose weight, etc. So these are the lifestyle modifications that one has to do, in addition to, of course, management of the primary conditions. So this way the atherosclerosis is at least under control. You also incorporate some bit of exercise rehab, if you will. And exercise rehab is important because that certainly conditions the exercising muscles. Now remember, the intermittent claudication, if it is occurring in the, say, which is most commonly occurring in the calves, and that's because of the gastrocnemius muscles. They utilize the highest amount of oxygen, if you will, in the entire lower extremity system while the person is walking. So the gastrocnemius, they're very, very vascular and they require a great deal of oxygen. So mostly the intermittent claudication is expressed by the patient in the calves. But if it is expressed further down, like into the tibial, into the shins, then one understands that either the tibials are involved, the peroneal arteries are involved, or the dorsalis pedi are involved. Okay, so exercise rehab certainly improves a great deal of these claudications that are occurring in different regions. Antiplatelet therapy is very, very important, and that can be initiated after asking the history of allergies, obviously. And once that is done, one can start aspirin, or one can start Plavix or clopidogrel. And Plavix seems to be very, very popular these days because of known aspirin allergies one sees. So one has to understand that. Excuse me. Vasodilators have some role, but they have not shown a great deal of success. So vasodilators like nifedipine and even diltiazem and many other, like if you're combining with ACE and ARBs, so you can use an anti-renin drug that might be helpful too. But people have tried to use Trentil, which is pentoxifylline. That's the Trentil is the trade name, and the pharmacological name is the pentoxifylline. And the other one is Platil, if you will, and Platil is the other name for that is silostazol. So these are the two drugs which people have used. And now all of this, if it fails, then next step is patient will undergo percutaneous transluminal angioplasty. This is just very similar to the PCI, if you will. As you recall, in the coronary artery disease, we do the coronary interventions. So here the intervention is done through the lumen of the artery, and it has to be done in a cath lab or in a peripheral arterial lab, if you will, or in the OR, where the surgeon is involved and the blockage is open, and then it's followed later by a stent. So very, very similar procedure done. And of course, if all of this is not, say, stent is not possible, or the arterial obstructions are long and the stents will not be helpful at all, then of course one resorts to peripheral arterial surgery, and reconstructions are done or bypasses are done, etc., etc., and one can use all these prostheses to really bypass those obstructions between the aortofem bypass, or it could be a fem popliteal bypass, or it could be popliteal tibial bypass, depending upon where the location in the limb that is in place. So in a nutshell, you've learned about peripheral arterial disease. We understand how you diagnose by various testings, including duplex, CTA, MRA, and contrast angio. And of course, the therapy management is really based on lifestyle modifications, including hypertension, cholesterol, and diabetes management first. Get them not to smoke. That's the biggest thing. You got to make sure that the smoking counseling is thoroughly done, because otherwise nothing is going to work. And of course, antiplatelet agents, sometimes vasodilators work, but if all of that fails, one resorts to PTA, which is percutaneous transluminal angioplasty. and then of course where the balloon is inflating the artery and then a stent is placed. But if the stent is not doable, if you will, if the arterial obstruction is long or extent is too far peripheral, then at that point one decides to do peripheral arterial surgery by bypassing or by actual reconstruction and applying some Dacron prosthesis. Okay, thank you again for your attention, and hope you're watching MuniMeterHealth continuously for other interesting videos that are coming down the pipeline. And we are constantly creating new videos, new information, new knowledge in every section of our video here for you. Thank you again for watching MuniMeterHealth. This is Dr. Sharad Jaitly. So long.